Okay, let's get started, and if anyone else joins, we'll just explain to them الحاجة اللي فاتتهم real quick. So yeah. So هنبدأ descending tracts this time. And the other descending tracts are basically the opposite of an ascending tract. So احنا قلنا ascending tracts كانوا sensory and they're from the receptors to the brain, right? معناته descending tracts are the other way around. They're from the brain to the muscles and it's motor. تمام? So يلا there's one thing about descending tracts that you need to understand. أهم concept يعني في descending tracts كله is إنه في حاجة اسمها upper motor neuron وحاجة اسمها lower motor neuron. تمام؟ يلا upper motor neuron يعني شنو و lower motor neuron يعني شنو. Upper motor neuron is the neuron that goes from the brain through the spinal cord all the way to حاجة بنسميها ال anterior horn cell. تمام؟ يعني if this is a cross section of the spinal cord, let me draw it better. If this is a cross section of the spinal cord, وعندنا في spinal cord sorry for the ugly drawing. عندنا gray matter, white matter. ال anterior horn cells دول بيكونوا هنا. تمام؟ وال anterior horn cell بيجيها ال innervation من ال brain through the spinal cord. وبعد ذاك من ال anterior horn cell it goes to the muscle. تمام؟ أي حاجة from this area from the anterior horn cell to the muscle بنسميها lower motor neuron. وأي حاجة from the brain all the way to the anterior horn cell بنسميها upper motor neuron. I'll repeat again from the start. إن إحنا في descending tracts basically عندنا tract from the brain to the muscle. It's motor innervation. So it's not sensory, it's motor. عكس الascending. يلا the thing about motor neurons or descending tract is that we have something we call an upper motor neuron and something that we call a lower motor neuron. And the أهم concept, and if you understand this concept, the rest is easy. So an upper motor neuron is a neuron بتمشي from the brain down through the spinal cord until its level of the spinal cord. And then in the level of the spinal cord, it stops في anterior horn cell. Then at the level of the spinal cord من anterior horn cell للmuscle the lower motor neuron. يعني if we're trying to move a muscle that's innervated by L1 for example هيقوم من البرين لحد level of L1 دي low upper motor neuron. بعد ذاك في level of L1 ذاته from the anterior horn cell to the muscle دي lower motor neuron. تمام؟ يعني a nerve that you do see outside of the spinal cord دي هي lower motor neuron. So for example, if we assume this is for example a sciatic nerve for example, if we say this is a sciatic nerve مثلا and we're getting L5 هنقوم from the brain all the way to L5 the upper motor neuron. في L5 ذاتها في upper وفي lower. في upper motor neuron ending وفي lower motor neuron starting. صح؟ يلا lower motor neuron is ever since the sciatic nerve leaves the spinal cord all the way to the muscle. دي كده lower motor neuron. رجعت لكم. So يعني if we were to cut any nerve ظاهر لنا برا but we can see outside the spinal cord دي احنا we're damaging a lower motor neuron. لكن if we're cutting in the spinal cord itself we're damaging an upper motor neuron. Get it? If we damage the horn cell itself we're damaging the lower motor neuron. تمام؟ يعني what counts as damaging the upper motor neuron is if you damage the brain or the spinal cord. لكن what counts as damaging a lower motor neuron is if you damage the anterior horn cell or the nerve itself. Make sense? Okay. طيب نعيد ال last part. The last part قلت إنه if you damage the brain أو you're damaging the spinal cord ده بيتحسب في جزء upper motor neuron. تمام؟ لكن if you damage the anterior horn cell أو you damage a nerve ذات نفسها قبل ما تصل للمصل ده كده if you're damaging a lower motor neuron. وقعت لك؟ تمام. That is great because this is like the most important thing. Like في ناس up until fourth year they sometimes mix them up, so it's important to know شنو. خلاص يلا upper motor neuron و lower motor neuron كده احنا فهمناه. Then we'll go to the tracts themselves. يلا tracts themselves عندنا pyramidal tracts و extrapyramidal tracts. تمام. البيراميدال tract بنسميه direct corticospinal pathway. تمام. direct يعني direct ده pyramidal والاكسترا pyramidal بنسميه indirect. تمام. So the basically namings of the two pathways we're going to be seeing. We're going to be seeing pyramidal pathways و extrapyramidal pathways أو direct pathway و indirect pathway. Usually they use a naming حق البيراميدال و extrapyramidal ده. تمام. So عندنا pyramidal و extrapyramidal. Clear يا جماعة؟ هنبدأ بالبيراميدال. تمام. يلا البيراميدال tracts فيهم اثنين. عندنا corticospinal tract و corticobulbar tract. تمام. corticospinal ده أهم tract, so it's like our main most important tract. So we'll focus more on it. الباقيين they're less important. تمام. يلا pyramidal tracts ديل أو corticospinal tract specifically. I'll draw them here الكلام. So basically their function is that they're supplying the motor to the body. الcorticospinal للبودي كله والcorticobulbar للhead and neck. تمام. يعني they give innervation أو motor innervation للبودي والhead and neck. So corticospinal is more important because it's the whole body, while corticobulbar ده بس للhead and neck. They both have حاجات similar شديد. تمام. نبدأ بالcorticospinal. يلا corticospinal في منه lateral corticospinal و anterior corticospinal. تمام. الانتيريور ده it's least, so it's less than 25%, while the lateral is most of it, so it's like 75% plus. تمام. So usually when they're talking about the lateral. يلا lateral corticospinal بيحصل له شنو؟ بينزل as one and then in the medulla it crosses or decussates in the medulla. تمام. while anterior it decussates في السباينال كورد في الليفل حقته. يعني نفس الفكرة حقت السباينال ثالاميك لكن بالمقلوب. So it's the complete opposite of the spinal thalamic, but the same idea. يعني most of it is gonna go and it's gonna decussate في الميدولا. So like هناك احنا كان عندنا dorsal column, the one that decussates in the medulla, right? So it would decussate in the medulla and go down, while there's a small part of it that's instead going to keep going downwards and decussate في level of the spinal cord. في النهاية كله هيمشي on the opposite side. تمام؟ يعني الcorticospinal tract ده most of it crosses or decussates in the medulla and a very small percentage of it decussates in the spinal cord. لكن احنا usually when we're talking about corticospinal we basically talk about a lateral. تمام؟ يعني most of the time we talk about the lateral. The effect of the lateral is more than the effect of the anterior. فهمتوني؟ يعني it's more important to talk about the 75% than the 25%. So if they're asking you a question, consider a 75% أكتر من 25%. تمام؟ يعني for example they be like the corticospinal tract decussates in the, your answer is going to be medulla. Like the 25% they act like it doesn't exist when it comes to questions that don't specify. تمام؟ And most of the questions are not going to specify. They're just going to say corticospinal and they'll be talking about a lateral of the higher. تمام؟ يعني lateral is the main one, which is the one that's going to decussate وين؟ في الميدولا. يلا الحتة اللي decussates فيها في الميدولا is known as the pyramid. So the area where it decussates is literally called the pyramid. That's why it's called the pyramidal tract. لأنه it goes through the pyramid في الميدولا. تمام؟ We good? طيب في تاني corticobulbar tract. هنا corticobulbar tract ده it also decussates the pyramid, and this time instead of supplying the body, it supplies cranial nerves. Now this part is a bit confusing, and يعني what happens is شنو؟ يعني عندنا it's from the brain, it'll go in the medulla, it'll decussate, and then it'll supply a cranial nerve. يعني instead of supplying the anterior horn cell، احنا قبل قلنا upper motor neuron دايما it supplies the anterior horn cell صح؟ هنا ده it doesn't supply the anterior horn cell, it supplies the cranial nerve nuclei. So the cranial nerve nuclei. وبعد ذاك النيرف اللي بتمرق من الكرينيال نيرف نيوكلياي ماشيه للبودي دي بنعتبرها lower motor. يعني let me repeat again. يعني النيرف اللي بتمشي من البرين للكرينيال نيرف نيوكلياي ده upper motor neuron. والنيرف اللي بتمشي من الكرينيال نيرف نيوكلياي للمصل دي lower motor. دي في حالة الكورتيكوبلبر يعني it's an exception. Did you get it يا جماعة؟ يعني instead of it being spinal cord or anterior horn cell, it's a cranial nerve nuclei في البرين stem. تمام؟ اوكي ما في تاني. يلا احنا قبل قلنا في upper motor neuron موضوع upper motor neuron والكلام ده like as you can see هنا قلنا انه بنسميه upper motor neuron ده بيمشي من البرين لحد الانتيريور هون سيل صح؟ بعد ذاك اللي بيمشي من الانتيريور هون سيل للمصل بنسميه lower motor neuron. تمام؟ يلا الكورتيكوبلبر تراك ده اصلا ما بيصل للسباينال كورد. It's for the head and neck, so it never reaches the spinal cord. It stops في البرين stem. فعشان كده instead بيبقى ال upper motor neuron from the brain to the brain stem, and the lower motor neuron is from the brain stem to the muscles أو to the whatever organ it is. تمام؟ فالبرين stem فيه ذاته where is it? It's in the cranial nerve nuclei. يعني let's take an example of a trigeminal nerve. تمام؟ نقول دي trigeminal nerve. طيب؟ الtrigeminal nerve ماشي to supply the muscles of mastication. تمام؟ I really hope you guys did that in anatomy because then I would just be confusing you. In the muscles of طيب عندنا البرين ستيم وعندنا المسلز الماستيكيشن. تمام؟ يلا عشان نمشي من البرين to the brain stem to the trigeminal nuclei ده كده upper motor. وعشان نمشي من trigeminal nuclei through the trigeminal nerve to the muscle of mastication ده lower motor. يعني احنا دايرين if we got a damage of a trigeminal nerve لو قطعنا هنا ده اسمه lower motor neuron lesion، لكن لو قطعنا هنا ده اسمه upper motor neuron. يعني لو ضربنا البرين ستيم ذاته دي upper motor. So brain stem injuries are upper motor, but injuries after the trigeminal nuclei move to the muscle of mastication, it's a lower motor injury. Make sense? Okay, تمام. طيب ده كده basically يعني الايديا حقت الكورتيكوبلبر ده بس بيحصل في الكورتيكوبلبر tract. Why? Because the corticobulbar tract is for head and neck, it's not for the rest of the body. While corticospinal is just like this diagram because it goes through the spinal cord and then it supplies the rest of the body. تمام؟ Are we good يا جماعة؟ So corticospinal for the whole body, corticobulbar is for the head and neck. And where do they decussate أو cross؟ في حتة اسمها pyramids in the medulla. That's why they're called pyramidal tracts. Great. So pyramidal tracts will decussate in the medulla. طيب يلا نمشي extrapyramidal. يلا extrapyramidal tracts ديل like they don't pass through the medullary pyramids or the corticobulbar tract, so they don't go through these areas. بيمشوا حتة تانية. تمام؟ and يلا ديل they usually start في حتة that's not in the brain. تمام؟ يعني they are spinal, بيمشوا spine, لكن they start somewhere else. إننا ثلاثة. إننا rubrospinal tract, vestibulospinal tract, reticulospinal tract. يلا زي just as like we did في موضوع في ascending, these three are not that important. So like don't bother too much with them. Try just to understand the idea حقتهم وهم بيمشوا من وين لوين وخلاص. Like don't bother too much with the details. A rubrospinal tract starts from something known as the red nucleus in the midbrain. تمام? So it starts from the red nucleus in the midbrain to the muscles. تمام؟ في vestibulospinal tract, it starts from the vestibular nucleus في pons, I think, yeah, في pons, and it goes to the body برضو. تمام؟ في تاني reticulospinal tract, it starts from the reticular formation and it goes to the body. يلا ديل فهموا شنو الثلاثة ديل. Their job is basically to control posture, balance, and equilibrium. So their job is to control your posture, your balance, and equilibrium. They also control muscle tone. تمام? So how much tension or tension your muscle has برضو is sometimes controlled by the extrapyramidal tract. تمام? So their function is your posture, your balance, your equilibrium, and your muscle tone. So how balanced you are, how much pressure you put, how you move, الحاجات دي are by the extrapyramidal. So for example لو حصل أي مشكلة للextrapyramidal, some of the symptoms you'll have is like tremor, حاجات زي دي. تمام؟ يعني تكون بتجف or you're unable to be balanced, stuff like that. I'll be giving it more details in a bit, but when we're talking about the clinical, but this is basically your idea of an extrapyramidal tract. You know, they don't pass through the medullary pyramids, or they don't pass through the corticobulbar tract, هم rubrospinal, vestibulospinal, or reticulospinal, and the nucleus, different vestibular nucleus, different reticular formation. Their main function is probably the most important part in this slide, in they control your posture, your balance, your equilibrium, and your muscle tone. تمام? Is it clear يا جماعة؟ Okay, great. طيب نمشي للنكست. الcorticospinal أنا كاتبة in details مع الcorticobulbar again, although I explained it من عندي, but let's just go through them again. Lateral corticospinal قلنا 75% to 90% of it decussates in the medulla, while the anterior corticospinal قلنا it decussates in the spinal cord. قلنا إنه ما بنشتغل بيه كتير. We focus mainly on the lateral corticospinal. قلنا الcorticobulbar which innervates the head, which terminates into the reticular formation near the cranial nerve nuclei. تمام? Association fibers leave the reticular formation and they synapse in the cranial nerve nuclei to form the lower motor neuron. And it supplies a contralateral cranial nerve. So one thing you need to know about النيورو ده كله إنه في كلمتين that you're gonna meet a lot. كلمة contralateral and ipsilateral. Contralateral means on the opposite side. Ipsilateral means on the same side. So basically, a corticobulbar tract is supplying a contralateral cranial nerve nuclei. So the facial nerve, for example, a cranial nerve nuclei on the right side is supplied by the corticobulbar on the left side. Make sense, يا جماعة؟ يعني دائما لما أي tract that crosses or decussates بيكون supplying the contralateral side. وأي tract that does not decussate بيكون supplying the ipsilateral side. تمام؟ نرجع نكتب بس الكلمتين دي اللي هم ipsilateral and contralateral. They're very important words for you guys to know. يعني الكلمتين دي make sure you know them very well. You know, ipsilateral means same side, contralateral means opposite side. تمام؟ Okay, تمام. طيب نمشي بعد that we're going to be talking about the clinical correlations of each. يلا when it comes to the clinical correlations أهم حاجة and like the most important thing you guys need to know is the difference between upper motor neuron lesions and lower motor neuron lesions. تمام؟ يعني if there was damage to any part of the body you need to know the upper motor or the lower motor. تمام؟ How do you tell them? It's basically by their symptoms. So the symptoms that you see are completely different than the symptoms of a lower motor. تمام؟ يعني upper motor neuron lesions you see spastic paralysis. يعني paralysis بيكون very strong. Your muscles are like tense. تمام؟ While a lower motor neuron فيها flaccid paralysis. So the muscles are very limp or like they're very light كده. تمام؟ في تاني increased tone في ال upper motor neuron. So المسل tone ذاته بيكون very strong, it's like against you. So بيسميه hypertonia. While في lower motor في decreased tone hypotonia. No? في تاني increased reflexes في upper motor. So if you're doing the knee jerk reflex for example بيكون excessive reflex. بيسميه hyperreflexia. While في lower motor في decreased reflexes بنسميها hyporeflexia. تمام؟ دي الحاجات الأولى. طيب في تاني no atrophy في upper motor neuron. يعني muscles that you see are زي ما هم you have normal muscles. While for lower motor neurons the muscles start to degrade, so you'd see atrophy in the muscles or the muscles are smaller than usual. تمام؟ So lower motor neuron you get muscle atrophy. في upper motor neuron you don't get atrophy لكن في حاجة اسمها disuse atrophy. يلا disuse atrophy دي basically is when you're not using your muscles they start to get degraded. Like say you, for example, if you've been going to the gym for a lot of time, you've been using your muscles a lot. If you stop going to the gym, your muscles start to go smaller. صح? Yeah, this is the same idea, but instead you're paralyzed. You're not using your muscle at all. You're paralyzed. So in this case, the muscles start to degrade. It counts as atrophy, لكن it's not atrophy due to the innervation. فهمتوني؟ يعني المشكلة بتاعتنا is just that we're not using the muscle. So if you're doing physiotherapy, for example, you would prevent disuse atrophy. Like if it's a lower motor neuron lesion, you get atrophy due to innervation being cut from the muscle. And the muscle is not getting innervation. So the muscle itself is degrading itself. Type atrophy is basically when the muscle basically shrinks or gets degrades or like it gets degraded due to a lack of use or due to a lack of innervation. So لما يكون lower motor neuron lesion المصل بيحصل لها atrophy because a lower motor neuron ذاتها is what makes the muscle keep its shape. يعني المصل ذاتها needs constant innervation to be in its shape. The moment you cut this innervation المصل دي no longer becomes in its shape وبتبدأ يحصل لها degradation. لكن في upper motor neuron yes you damaged the spinal cord لكن الnerve ذاتها is still intact. So this nerve it's still keeping the muscle in its shape. However, if you stop using the muscle is just going to start degrading due to the fact that you're not using it. فهمتوني؟ Okay, perfect. طيب تاني في حاجة في extra signs or symptoms. في lower motor neuron في حاجة اسمها fasciculation وفي upper motor neuron في حاجة اسمها Clonus. يلا ديل basically they're both kinds of contractions. طيب يلا Clonus is basically your muscle literally how do I explain it? You could guys Google a video of it because it's best if you actually see it. But Clonus is basically المصل حقتك would be like if you were to push the muscle. لا مش push. Let me explain it better. Let's say you got the ankle of the patient, right? And you pushed it. When you let go of the ankle, the muscle is literally going to start moving right and left, right and left, right and left. تمام? Yeah, okay. Let me repeat again. So we'll repeat again. An upper motor neuron قلنا عندها spastic paralysis. So the paralysis of it is really strong. The muscles are like really tense. Here increased tone. So again, it's really tense hypertonia. The tone of the muscle is really strong. بنسميه hypertonia. وبكون no atrophy except due to disuse. So if you're not using the muscle, it'll start to atrophy but not as much. في تاني increased reflexes, so if you're to do the knee jerk reflex or any other reflex it would be really excessive تمام. So بنسميها hyperreflexia. في lower motor neuron ولا في flaccid paralysis, so the paralysis is just يعني almost like the muscles aren't being used. المصل بتكون خفيفة كده like really light. في decreased tone which we call hypotonia. Atrophy, which is basically the muscle starts to shrink and get degraded due to the lack of innervation. The decreased reflexes, which is basically what we call hyporeflexia. And في حاجة أخيرة, which we call clonus and fasciculations. They're both abnormal movements that are found in the muscle. Yalla, to actually show them to you, I can't, and if I try to explain them, it won't make sense unless you actually see them. So yeah, if you guys have the time or energy, you can go and look at it online, like a video, short video. Fasciculation is basically like a twitch, like a muscle twitch. While clonus, like a muscle zata, starts to move. But I can't exactly explain to you what it looks like until you actually see it. You get me? You'll see it in third year for clinicals in mustashfa. Like up until then, I can't exactly explain to you what it looks like. You get me? If I find a video on YouTube or something, I can send you guys the link. Like, I can't really explain to you what it looks like exactly. And it's really difficult to imagine يعني. But في حاجة أخيرة اسمها Babinski sign. حاجة أخيرة اسمها Babinski sign. And Babinski sign is basically if you take the dorsal root of the bottom of the person's foot and you pass this like maybe a key or any instrument along the foot margin, the toes start fanning out. So they start fanning out كده. تمام؟ يلا, if that happens, بنسميه positive Babinski sign. If it doesn't happen, بنسميه negative Babinski sign. If it happens, it's a sign of upper motor neuron lesion. If it doesn't happen, it's a sign of lower motor neuron lesion or normal person. تمام؟ I'll repeat it again. What happens is إنه يعني بتجيب رجل العيان, like the foot of the patient, and I can't draw a foot properly. Like, let's just try. Let's say this is their foot. Yeah, you take the foot and you move an object to the border of their leg, like around their foot. تمام? And then you see what their toes do. يلا, if the toes move in a fanning out direction, يعني بيتفروا كده, like if the toes literally move away from each other, ده بيسميه positive Babinski sign. يلا, positive Babinski sign دي, it's a sign of upper motor neuron lesion. تمام? يعني they either tell you in the exam, like actually a patient has positive Babinski sign, or they would be like, patient, when you did the test, their toes fanned out, or their toes, yeah, usually the word is fanned out or fanning out of toes. تمام؟ and حاجة مهمة تانية is just not just the toes fan out, but like the big toe itself gets flexed. So the big toe gets flexed while the rest fan out. So that's basically the definition of a Babinski sign. The big toe is flexed, the rest of the toes are fanned out. تمام؟ طيب, دي كده basically الساينس حقت ال upper motor neuron, lower motor neuron. طيب, يلا, when it's an upper motor neuron lesion, في مرات extra signs. لو ال upper motor neuron قطع بس ال pyramidal ولا extra pyramidal. يعني when there is extra pyramidal upper motor neuron lesion, في extra signs that you see, which are tremor or rigidity. طيب, so if you're damaging just the upper motor neuron of the pyramidal, you'll get these signs. Like if you're damaging the pyramidal and extrapyramidal, you'll get these signs as well, which are tremor or rigidity. تمام? Tremor, basically your hands or feet are going to be trembling, so your tremor بترجف. And rigidity is basically that when you're moving the arm, it starts really strong and then it suddenly becomes really light. دي حاجة اسمها clasp knife. So basically زي المطوة, Have you ever seen like a pocket knife? When you open it, when you're trying to close it, في البداية, there's resistance. And then there's no more resistance and you can close it. ده بنسميه clasp knife rigidity. And it's a sign of upper motor neuron. Did you guys understand the concept of clasp knife rigidity? Or do I repeat it? يعني basically لو ده الelbow حق البيشنت, ده their elbow, ودي their hand. And you're moving their hand, you're literally pulling their hand. At the beginning, it'll be really tense. And then suddenly it'll become no longer tense. It'll just go really quickly with you. دي كده بنسميها clasp knife rigidity. Make sense? It's a sign of upper motor neuron lesion. طيب. Next عندنا disease ثاني اسمه syringomyelia. It's very annoying. I hate it. Syringomyelia, basically what happens is that it's a developmental abnormality. So it's embryological problem where the central canal of the spinal cord is dilated. Yeah? يعني a central canal of the spinal cord starts to get dilated enough that it's damaging tracts الجنبة. So the tracts that are found closest to the central canal get damaged. Okay? So due to that, it happens mostly في the brainstem, في the cervical region. So usually in your neck. And the symptoms كلها بتكون upper limb و neck symptoms. تمام? So basically it looks, if you look at the symptoms and signs, it always happens في الarea دي كده. Because you're only damaging the cervical region usually. تمام؟ الsymptoms حقتها كثيرة, but it's not as common to be in exams, so don't worry too much. Of course, sure. Yeah, basically, its cervical region gets damaged by the spinal cord because of the developmental abnormality in the central canal. Got it? تمام. طيب يلا عندنا هنا يلا السيمتومز كلهم بيظهروا في areas of the upper limb or like upper chest. تمام؟ يعني هنا because the cervical region is the brachial plexus وكده تمام؟ So it's affecting this area. It can descend to the beginning of the thorax لكن يعني usually it stops في الحتة دي. تمام؟ يعني usually في upper limb, shoulders, the area دي like an area that's shaded in this picture. تمام؟ So the symptoms are loss of pain and temperature bilaterally in dermatomes affected by the segments. So معناتها if you're losing touch and temperature, it means your spinothalamic tract is damaged, right? So you're damaging the spinothalamic on both sides. So you lose pain and temperature. However, your posterior column isn't affected because the posterior column is far from the central canal. عشان كده vibration, proprioception, or 2-point discrimination are there. Okay, there's a question saying why does it affect only that area? Okay, basically a disease ذاته بيكون في مشكلة في is the issue in the central canal starting from the top. Like it starts from the neck, the central canal starts widening and widening and widening and damaging areas. It starts in the neck and it progresses downwards, but it usually takes a lot of time to reach down. So when the person shows up with the symptoms are probably only reaching the upper limb or like the beginning of the thorax. Make sense? Yeah, it's a progressive disease that starts from the neck downwards. Type. So again, you lose pain and temperature عشان the spinothalamic tract gets damaged. يعني احنا لو imagine إن قلنا دي spinal cord عندنا مشكلة في السنترال canal, أقرب tracts للسنترال canal هم الspinothalamic. So the spinothalamic get damaged, but the dorsal column is really far away from it, so it doesn't get damaged. تمام? You also get lower motor neuron weakness في small muscles of the hand, so it affects the hands lower motor neuron ما upper motor. تمام. So these are what happens. So you get pain and temperature in spinal thalamic, and you get lower motor neuron weakness in hands. يلا, the lesion can expand. They can expand over time, so it can affect other muscles, and it can affect the shoulder, the arm, كده. If further expansion affects the white column, it can affect the descending tract, causing paralysis or spastic paralysis. يعني it can progress to cause to affect the other muscles of the arm and shoulder, and eventually affect the column, posterior column, which causes bilateral spastic paralysis and so on. But usually, it's only in the lower motor neuron of the hands and the pain and temperature of the upper limb. تمام? If the zoom cuts, we'll come right back.